Hello guys, am I audible and visible? If so, say me and hi. Sorry for again disturbing you on an afternoon. I was supposed to take class by yesterday night and it got rescheduled. Fine. Okay, am I audible and visible? If so, a hi would be appreciated. And if things are good, let's start the RBC disorders. Okay, guys are not there. Hopefully. Fine. Okay, so let's start. So we'll go the same template based thing, whatever we are doing for the entire Farre. I'll primarily talk about RBC disorders, and if required, we'll kind of do coagulation sometimes later, right? Good afternoon, Samantha. Fine. So now, for an hemolytic anemia, if you divide RBC disorders, there are two main groups. One is hemolytic anemia, other is nutritional anemia. These are two main groups, right? For hemolytic anemia, I want you to have the same template. Remember this template, whatever may be the hemolytic anemia, if you can fill these 6 headings to 2 points, that should be more than enough, right? Good evening, Sai. Good afternoon, Sai. Good afternoon, Lion. Okay. So we have to talk about the etiology. If it's inherited, what is a mutation? If it's inherited, the inheritance as well. And talk about the defect, whether it's inside the RBC or outside the RBC, because this is how the hemolytic anemias are classified, intra or an extracorpuscular defect. A word about the pathogenesis. There is a template pathogenesis. If it's a lysis in the spleen, you know how it goes. If it's a lysis directly, you know how it goes. Just a word about them, maybe a couple of 2-3 lines to add on to it, whether lysis intravascular lysis or an extravascular lysis. And under diagnosis, I want multiple subheadings, all these three. So history is also a part of the diagnosis. Don't ignore it. We need that. CBC findings, when I say CBC, it means the MCV, MCH, MCHC, whichever is relevant, write them. Other things, ignore them, right? And peripheral smear, obviously, that is the clue to say whether it's a spherocytosis or a G6PD or a sickle, right? And finally, the investigation of choice, right? If required, and if you have a strong confidence about the treatment, write a word about the treatment as well. Fine. Thank you, Bharat. Hope you become more better than me. Fine. Okay. So this is the template for every hemolytic anemia. I'm going to ask you questions. You guys are going to answer because I'm sure that you know that we are discussing RBCs today. I'm sure you must have done that RBC, right? So once you automatically engage, you interact in the main exam, when you write, all these headings automatically will come. See, 5 diseases. We do the same headings again and again. It becomes a routine. That's all. Fine. Okay, let's go ahead. Can anyone tell me what is the etiology of hereditary spherocytosis? Is it acquired or inherited? We'll go step by step. HS is undoubtedly inherited, right? So the etiology of spherocytosis should be mutations, right? If you want, write all the possible mutations. You have to start with, they are going to be primarily mutations, which is going to be involved in your vertical interactions. Proteins in the vertical interaction is what is going to be there. If at least one, anchoring at least is more than enough, like Lion said. If you want, write anchoring, band 3, everything. Whatever is required, you write spectrin, everything. But at least the most common mutation will be in a protein called as an ankyrin. Ankyrin is undoubtedly the most common mutation that at least is required for us for representative and things, fine? Okay, that's one. Okay, so it's an ankyrin mutation. Spectrin can also get mutated, band 3, band 4.1, everything can get mutated, but at least most common ankyrin mutation. What is the inheritance? Ankyrin is a structural protein. We know the template for writing inheritance. If it's a structural protein, it has to be dominant or recessive. Most of the structural proteins are dominant and it is present in an autosome. So I have an autosomal dominant inheritance. Fine. If you want to go for a gold medal exam or if you want to be the university topper, maybe put a comma and write autosomal recessive inheritance in cases with spectrin mutation, right? This is rarity, but spectrin mutation can be autosomal recessive inheritance, right? Hello, Binnaman. Hopefully you're doing good. Okay. So now let's come to the pathogenesis. Because of the mutation in the ankyrin or spectrin or the bands, what happens is RBC from a normal biconcave shape becomes spherical. Okay. Whenever you draw a spherical RBC, I want you to shade it completely. Again, subtly telling to the examiner, see, I know what's there, right? So this spherical RBC, when it goes via the spleen, they get trapped. They'll be trapped in the spleen, and who will eat them in the spleen? Obviously, it will be engulfed by the splenic macrophages. Write the splenic macrophages, or if you want to add and write littoral cells, be my guest, whatever you want, it will be eaten by macrophages. So primarily the lysis intravascular or extravascular? It is a primary and extravascular hemolytic anemia. Fine. It's undoubtedly an extravascular hemolysis. Write this also because this makes important thing for me to understand the symptomatology and the examination finding. Fine. Perfect. Simple terms. You need not use complicated stuff at all. Normal becomes spherical, goes into the spleen, gets trapped, eaten by the macrophage. That's all, right? Now let's go to history. Diagnosis starts with history, CBC, peripheral smear, investigation of choice. One word also is enough for me, but we can write more than one word. It's an autosomal dominant disorder. We know the routine. Present during children or adults. Extra as it happens outside the blood vessel, so we call it extravascular hemolysis. Okay. It presents during adults. Perfect, right? It will present during an adult, most likely a very mild amount of hemolysis. For the simple reason it's dominant disorder. Dominant disorder, one gene is normal, has to be in mild hemolysis. Since they are mild hemolysis, they generally do not present with fatigue. Might be 11 grams, 10.5 grams. They won't present with fatigue, right? So most likely the presentation is due gallstones. Pigmented gallstones or cholesterol stones. Gallstones is the common presentation for HS, and there'll be obviously a pigmented gallbladder calculi. If it's a cholesterol stone, it is not due to hemolysis. Only a pigmented gallstone is due to hemolysis, right? Can I say this patient will have splenomegaly? Is that statement right? Splenomegaly, yes, no, maybe. Extravascular hemolysis, spleen destroys them. What will happen to the size of the spleen? They'll by default be enlarged, right? So by default, the patient will have splenomegaly. Splenomegaly will be present. On examination, it will be present. An adult with splenomegaly presenting with a pigmented gallbladder calculi and hemoglobin slightly reduced, I think of an hereditary spherocytosis. That's by default, right? So CBC finding, like I said, there are few things important for me. You need not write for everything hemoglobin is less. Hemoglobin will be less in every anemia. If you want to extra bill pages, write it. Be my guess, right? If it's not required, it's not required. That's all, right? Next, the most important thing is it's a smaller RBC. The smaller RBC, concentrated RBC, what will happen to the concentration of hemoglobin? It will become elevated, right? This is a very, very classical finding. Elevated MCHC is a classical hallmark finding for every spherocytes. Don't miss that. I don't look for anything else in case of spherocytosis. MCHC will be elevated. That is seen only in this condition, no other condition. Very, very classical thing, right? Then we'll come to peripheral smear. So in peripheral smear, you will see spherocytes. The question is simple. How do you identify a spherocyte? Anyone? They are smaller than the normal RBC or they are bigger than the normal RBC? They are undoubtedly smaller, right? So here, draw a representative diagram. Put a diagram in the corner. Draw a normal RBC. I am sure you guys by this time you know that normal RBC is a central palar, right? That's very, very important for every normal RBC. Central 1/3 will be pale, right? So this spherocyte will be smaller than a normal RBC, will be darker. That's why MCHC is elevated, and there'll be no central pallor, right? So my spherocyte will be like this. Spherocyte will be like this. A spherical RBC, no central pallor, right? Write them. A spherocyte will be smaller, darker, and there'll be no central pallor. That's a very classical thing. You will never have a central pallor in case of spherocyte, right? This is how a normal spherocyte looks like. Mark them. If you want, put a mark saying that it's a spherocyte, and if you want, put a mark saying that that's a normal RBC. Fine. So we know. We also convey to the examiner. I know how it looks in microscopy, and I also know how to identify spherocyte. If you want, directly jump to investigation of choice. But if you feel again you want to drag the question a little bit more, the next question: whenever there's a spherocytic anemia, what do we do? What's the test we do? If you find a spherocytic anemia in any person, be it a young or an adult, we look for. Perfect. We do a test called Coombs test because we have to rule out autoimmune hemolytic anemia, right? Perfect. So next step here, the next step is we do a Coombs test. Coombs test will be negative in case of an hereditary spherocytosis. It will be positive only in case of an autoimmune hemolytic anemia, right? I do have one more test. Maybe if you want, write it. Screening test, though it's not required. We have a test called an osmotic fragility test. I've told in the main lectures why it's not required, but if you want to make the examiner happy, especially an older examiner, osmotic fragility test uses a screening test, right? Undoubtedly, final thing is going to be my investigation of choice. Can anyone tell me what's the investigation of choice for hereditary spherocytosis? They look for the band 3, that's a topmost protein's presence, with the help of a molecule called as EMA, eosin 5-malleamide, right? So we have EMA flow cytometry. Flow cytometry is undoubtedly the investigation of choice. If you want to write flow cytometry, that's great. If you add EMA, that's amazing. That's all. If you write flow cytometry itself, is very, very good for an undergraduate level, right? Okay. Now let's see treatment. Can anyone tell me what will be the treatment for an spherocytosis? Treatment is simple, right? If at all, if I need something, I remove the spleen. If at all there's a very severe lysis, we do a splenectomy. EMA is a protein, Samantha. It binds to the topmost layer of the vertical interaction that helps to diagnose your spherocytosis. Fine, that's it. Fine. Again, if you want to write more, there are two crises in every hemolytic anemia: hemolytic crisis, aplastic crisis, the parvovirus, and all the Epstein-Barr virus, malaria, and everything. Add it to it. Generally, it's not required, not very often seen, but if you want to add, you can add it, right? Simple words. It's nothing much to memorize, only this. Etiology, if you want, write the defect, inheritance, pathogenesis, few words for diagnosis, a word about treatment. This is more than enough for every hemolytic anemia, and you can revise the entire RBC chapter within no time. Simple, one word is enough. If you know one word, I'm 100% sure you can write half a page. Right? We have trained you, right? Anatomy, physiology, and biochemistry was for that. How to write stories without even knowing things, right? College will teach you. You'll have community medicine the next year. You'll learn more than that. Fine. Let's do the same thing for your G6PD deficiency. What's the etiology? Etiology, it's there in the name, right? There's a defect or an reduced G6PD levels, right? Reduced G6PD levels. That's the problem in G6PD deficiency, right? Simple, G6PD deficiency. Inheritance, anyone? It's an X-linked recessive inheritance. Obviously, this also is an intracorpuscular defect. It's a problem inside the RBC because it's an enzyme defect which is obviously present inside the RBC, right? It's an X-linked recessive. Whenever you write X-linked recessive, I have already one statement ready for my clinical history. Affects men more commonly than women. Every X-linked recessive disorder is going to affect men more commonly and women will be carriers, right? Now let's look at pathogenesis. So whenever there's a reduced level of G6PD enzymes, by default, it will have a reduction or it will stop the working of which pathway? HMP pathway. If the HMP pathway is not working properly, there will be reduced amount of NADP, NADPH. Okay. Because of reduced amount of NADP, NADPH, there will be reduced recycling of glutathione peroxidase. What's a glutathione peroxidase? It's a free radical scavenger. It's an antioxidant, right? So when there's a reduced recycling of glutathione peroxidase, especially since RBCs don't have a nucleus, they cannot synthesize new glutathione peroxidase. By default, this results in your increased reactive oxygen species induced damage to RBCs. Okay, it's just more reactive oxygen species there and it damages the RBCs more. Fine. That's all is the pathogenesis. Again, if you write in vertically, it will be much comfortable for you. It will fill easily half pages. If you want, if you're very confident in biochemistry, add a few words about HMP pathway, add a few words about glutathione peroxidase, reductase the cycle, not required. But ultimately, I want to know this. If G6PD is reduced, the problem is not direct, it's indirect action by free radical scavenging defect, right? It's more reactive oxygen species damaging the RBC, that's all, right? Now I have history. History, like I said, one, it more affects males. Males are more involved because we have a history of X-linked recessive inheritance, right? It is a free radical induced damage. So the second and the most important word in the history is it's always a trigger induced hemolysis. It's not, very few times it'll have a flat curve of hemolysis always, right? Most of the time, this word is very, very important. It's a trigger induced hemolysis. Fine. It's a trigger induced hemolysis. That's important here. Since reactive oxygen species directly in destroying the RBC inside the vessel, will the patient have hemoglobinuria, red color urine or hematuria? Obviously the patient will have, right? So trigger is induced hemolysis. The trigger are most likely infections. Infection is the common trigger. Drugs could be a common trigger. Fava beans, favism could be a common trigger, right? You can write that. Again, I'm just writing a word. You can definitely have an extra 2 or 3 sentences written for everything, right? It's just a word for now, fine? So it's a trigger-induced hemolysis. The triggers are infection, drugs, or fava beans. That's how it is, fine? Then, obviously, the patient will have hematuria. The patient might present with hematuria because it's an intravascular and also extravascular, but intravascular hemolysis is there. Why trigger, Samantha? It's simple. Only when there's a trigger, you'll have more of reactive oxygen species, and that reactive oxygen species will cause more damage, fine? CBC, I don't have any classical findings apart from a sudden drop in hemoglobin. Because the trigger induced, it will be completely normal. Suddenly there will be hemoglobin drop. Completely normal. Suddenly it drops. I think of a trigger induced lysis, right? Peripheral smear, 2 classical findings in Leishman stain, In Leishman stain, I look for two findings. One, the most diagnostic finding here is bite cell. I'm sure we have read about bite cell a lot, right? Second, since it's a reactotoxin species damage, this can also damage the RBC subtly. This can also have spherocyte, right? So you'll have spherocyte as well as you'll have bite cells. That's classical. And I have finding in new methylene blue stain. If you don't want to write NMB, most of the pathologists know what is NMB. If you feel that you have to write new methylene blue, write new methylene blue. What's the inclusion body in new methylene blue stain? Anyone? The classical inclusion body which is seen here, which is perfect. You have your Heinz body. Heinz body will be classically seen in case of a new methylene blue stain. Otherwise, you're just going to have a normal Leishman stage, bite cells, and a spherocyte. Perfect. So once I have all these findings, obviously the next thing I'm going to talk is investigation of choice. What do you think will be the investigation of choice? It's an enzyme analysis, enzyme defect, right? So it's an enzyme defect. My treatment is simple enzyme analysis. That's all, right? Again, a word about treatment. It's a trigger-induced lysis. So what do you think you can treat? Patient had an infection, had hematuria, had lysis. So it's simple. Take care of during that time. That's all. Supportive management. Whenever I use the term supportive management, it's very non-specific. If there's a drop in hemoglobin of more than 4-5 grams, give blood transfusion. Only 1 gram drop. Observe. That's all. Next, and the most important thing is try to avoid the triggers. I cannot avoid an infection, but I can definitely avoid the drugs, right? We can stop giving primaquine, dapsone, few classical drugs which is known to cause hemolysis. Stop that. Stop eating fava beans. That obviously can be done. Rest a supportive management. That's all. Fine. Rahul, you tell me what's the problem. I'll try to definitely help you with it. Fine. Lion, ideally, in case of an hemolytic anemia, most of the time I won't have a problem with WBC and RBC unless it is like a pancytopenia in case of PNH or in case of an aplastic anemia. If it's anemia, my main focus is going to be on the RBC. If you want, add and write a word, WBCs will be normal, platelets will be normal. Again, it's about writing papers, that's all. They will be normal, right? When I'm talking about leukemia, actually I need not talk about an RBC. It's not required, it's implied it will be normal, but I feel that it gives more structure to the paper, please go ahead and write it, right? Okay, next let's go to same template, sickle cell anemia. Etiology, this is the only mutation which we have known for years, right? Okay, this is the only mutation which we can know for years, right? Okay, just give me a second. So here, etiology, what we have here is, there is a mutation in the beta globin chain. In the 6th position, we'll do it. Rahul, tell me what's your doubt, Rahul. I'll definitely reply. You tell me what's your doubt. We'll see. We'll definitely understand. Okay. 6th position, you'll have glutamic acid will be replaced by valine or lysine. Will be replaced by valine, right? Because of this replacement, what happens is there'll be a reduced solubility of hemoglobin. Please do write this. This is very important for us. I'll have reduced solubility of hemoglobin. That's the primary reason here. Fine. Perfect. Okay. Lysine will be seen in case of an HBC. Here I'll have valine replacement, right? Sickle cell anemia, dominant recessive. It's undoubtedly autosomal recessive inheritance. It's an autosomal recessive inheritance. There's a change. That's it, right? Pathogenesis, because of the reduced solubility of hemoglobin, we'll start with the same thing what we mentioned in the etiology. There'll be clumps of hemoglobin. Obviously, when it's not soluble, you'll have clumps, right? So once you have clumps, these clumps can do two things. One, it can cause membrane damage. This membrane damage can be irreversible, right? It can also cause reversible membrane damage, right? Because this clumping is reversible based on the oxidation state, it can cause a membrane damage, which can become an irreversible sickle RBCs. Once it becomes an irreversible sickle RBCs, it's like this. They get stuck in the spleen, and in spleen, they'll be lysed. That's how it causes anemia, right? It's an irreversible membrane damage getting stuck in the spleen causes anemia. The problem in sickle cell anemia is actually not anemia. That also is a concern. But the main concern is the reversible RBCs, right? These reversible RBCs are sticky. If they are sticky, they're going to occlude vessels. Once they occlude vessels, it can cause all your vaso-occlusive crisis. Fine. It can cause your vaso-occlusive crisis. That's what is going to happen in case of an sickle cell anemia. Okay, sorry for this. The vaso-occlusive crisis is most diagnostic. It's the one which is going to give most clinical symptoms than the anemia per se. If you want to add more, say I feel that this is more than enough, but if you want to add more, you can write places where the sickling will happen. There are factors which promote sickling, like an inflammation, like a deoxygenated state, like in lower limbs, like in veins. Factor which will reduce sickling, any oxygenated state will reduce sickling. Those are the things which will alter the dynamics. Fine. Now let's come to history. History is predominantly based on your vaso-occlusive crisis. Fine. History is mostly predominantly based on vaso-occlusive crisis. One second. Okay. So any low pH also we can write it, Ramesh. Fine. So history is predominantly, like I said, it's based on vaso-occlusive crisis only. Anemia is definitely there by default. The most common vaso-occlusive crisis is dactylitis. Rahul, bolo, aap kya samajh nahi aaya? I'll try to explain that. No, you keep saying you're not understanding. Tell me what you're not understanding. Fine. Okay. Most common is dactylitis. That's the first one, right? Next, you obviously will have multiple things. A chronic non-healing ulcer of the leg. We know the explanation, right? The patient might have multiple infarct in the abdomen, an unexplained abdomen pain. These are nothing but tiny infarcts in abdomen. Okay. After that, this might end up on later stage in autosplenectomy. Okay. Obviously, Devangan, yes, a repeated cycling of reversible sickling at one point of time will make them irreversibly sickled. Right? It's a cycle which I have not mentioned here. You're right. Fine. Okay. Then we'll also have priapism as a classical finding. In most of the men, they present with priapism. Again, it's a reason due to vaso-occlusive crisis. In worst case scenario, one of the worst complication here or an emergency could be an acute chest syndrome. All of them could be clinical features. The patient might have an acute chest syndrome. Again, if it's a long answer, write long. Dactylitis, inflammation of the digits is dactylitis. Fine. Okay. If it's long answer, write a word or line for everything. If it's a short answer, just mention the symptoms. In addition to this, obviously the patient will have anemia. Anemia is due to fatigue and all those things will be there, right? CBC findings, I don't have much of a classical finding except for the reduction in the hemoglobin, that's all. Priapism psi is an painful erection of penis because penile erection is a vascular phenomenon. These sickled RBCs will block the veins, so there'll be less venous drainage, there'll be an engorgement of penile structure, right? That's called priapism, fine? Okay, let's come to peripheral smear. Peripheral smear, the first and the most important finding for me is simple. It's your same sickled RBCs. That's the most important finding. Can anyone tell me any other finding apart from sickled RBCs? Samantha, because skin in the lower limb will have more of deoxygenated state, that will cause it. Based on that, it can reverse. Fine. Okay. Sure, Movikas, we'll do it. Rahul, so that's a problem, right? You are in 11th standard, so this is MBBS second prof lecture. Join MBBS, we'll learn and you'll definitely understand Rahul. Perfect. You can have a target cell, that also can be said. That's one. Then spherocyte. Perfect. That also can be there. That's also one, right? So you'll have spherocyte, you'll have sickled RBCs, you'll have target cells. All these are classical peripheral smear finding, right? So once you see a sickle cell, that's more than enough for me to confirm the diagnosis. If I want to confirm the diagnosis, what's the investigation of choice? Investigation of choice for any hemoglobinopathy, these are the two ones, HPLC, better than hemoglobin electrophoresis. That's how we confirm the diagnosis. Both of them are good enough for us. Sickling test might be required in case of a sickle cell anemia trait. If I see a sickled RBC directly in my microscope, I won't require that. Again, if required, there's a screening test. I want to screen the recessive patients, especially traits. We have a test called a sickling test. You induce a deoxygenated state, force them to sickle, and obviously you suck out all the oxygen by mixing with sodium metabisulfate. It will automatically remove the oxygen, which will cause sickling test. Screening test, that's all, fine. Treatment? Anything about the treatment? Simple treatment. One of the classical treatment is there. Okay. So one of the classical treatment here for an sickle cell anemia is your drug which increases your oxygen levels. Anything? Perfect, right? Hydroxyurea. Hydroxyurea is by default one of the important thing, and maintain the saturation. If I can maintain oxygen saturation close to 100%, that's the best thing for me. Obviously, I might require, especially in a sickle cell anemia, full-blown sickle cell anemia or a homozygous sickle cell anemia, blood transfusion might be required based on the amount of hemoglobin. If it's a very severe lysis, we might require a recurrent blood transfusion. For all the crisis episode, we can take care of this. And if it's to maintain oxygen saturation, also will reverse the sickling, fine. Samantha, how malaria, see, malaria will not be associated with this. Since the RBCs are sickle, the lifespan of the RBC will become smaller, less. So malaria cannot sustain inside one. Then one of the stickiness element of the Plasmodium falciparum, because of sickle nature, it will not be able to express it, right? So incidence of cerebral malaria, falciparum malaria will be less in case of a sickle cell anemia, fine. Perfect. CRISPR is the latest technology. If I want to cure sickle cell anemia, I can do a gene therapy, or the gene therapy ways CRISPR, fine. Okay, that's about sickle cell anemia, right? Then let's go to thalassemia. Same template, same findings. See, it's very simple in RBC because every disease in RBC falls under this template. If it's not falling under a template, we'll lead it later, but most of the disease will fall under a template. It's very, very simple to understand that, fine. Etiology of thalassemia. I'm going to primarily talk about beta thalassemia. If it's alpha thalassemia, you know how to change it. Beta has 2 alleles, alpha has 4 alleles. So you have 4 different types of alpha thalassemia, 2 or 3 types of beta thalassemia, right? So here I'll have mutation, okay, IVS 1 to 5, G to C. Okay, G to C, there's a common mutation seen, or a 619 base pair deletion. These are 2 common mutations seen in case of an, or if it's very difficult to remember this mutation, just write them. There's a splicing mutation. There's a splicing mutation. Same time, there's a chain terminator mutation or a deletion, which happens, which reduces the beta chains, the beta globin chains, or it will make them zero globin chains. Based on the different permutation combination, if it's a reduced beta chain, I can call it a beta thal minor. If there's no beta chain at all, we'll call it a beta thal major. Okay, fine. It obviously is an intracorpuscular defect because the problem is inside the RBC. Inheritance of thalassemia is also same, autosomal recessive inheritance, right? That's how most of the inheritance of hemoglobinopathies are, fine. Now let's look at the pathogenesis. One main difference here is in the pathogenesis, here it starts from the bone marrow, because the hemoglobin is produced way early in the erythroblast stage. From that stage we'll have an affection, right? And the main problem in the pathogenesis is not the reduced beta, it's the excess alpha. In alpha thalassemia, the problem is not the reduced alpha, it's the excess beta or excess gamma. That's a problem, right? So in bone marrow, because of no alpha beta chain, I'm talking about beta thal major, you will be replaced by 4 alpha chains, because without having 4 chains, hemoglobin cannot be formed. These 4 alpha chains again will clump together. The same protein, I cannot form a quaternary structure, they'll collapse. That's what clumping happens, right? And this clumps will be in your erythroblast. It's not like sickle cell anemia where the clumps happen in the RBCs. Here it happens in the blast, right? So once you have clumps in the blast, let's draw a blast and high NC ratio and tiny clumps. This clumps will cause membrane damage. So once there is membrane damage, there are 2 outcomes for every membrane damage. If it's very, very severe membrane damage, it will lyse the entire cell. Once it lyses the entire cell, automatically you'll have bone marrow having hyperplasia. You can write that as well here. Okay, I am writing horizontally. Please write vertically. It will be much more neat and it will occupy space also, right? If it's a less severe damage, membrane damage, so it might result in smaller blast and an irregular blast. You'll have small blast and irregular blast. This small and irregular blast are the one which is causing your microcytes, anisopoikilocytes, target cells, everything. So the microcytic RBC, and you have anisopoikilocytosis as well. Including a target cell, the reason is due to an irregular blast being produced, fine. Also your target cells, fine. So we know what's happening. There's lysis because there's tremendous amount of lysis, I am not able to maintain the RBC pool. That's what is going to cause anemia. Fine. I'm talking everything about major. History wise, again talking about beta thal major, the patient presents in around 6 months of age. Till that time, you'll have hemoglobin F, alpha 2, gamma 2, beta thalassemia will not present, right? After that, you'll have classical failure to thrive. Kid will not grow properly. Mostly thalassemia comes in a long answer. So they won't need to ask you clinical history because that will there be in the question. Fine. Perfect. You'll have failure to thrive. You'll have frontal bossing, the chipmunk faces, and all those things, prominent zygomatic arch, all the classical hemolytic phases, and obviously the patient will have repeated blood transfusion. All that will be in the history of a long question. If it's a beta thal minor, mostly it will be similar to an iron deficiency anemia. Just the patient will have fatigue. Patient presents unexplained fatigue, weakness, tiredness, like a normal iron deficiency anemia. The patient will not have classical hemolytic phases, might not be having failure to thrive, might have a decent normal, till adolescence, they may be decently normally present. Fine. Again, coming to CBC, TAL is an microcytic anemia or a macrocytic anemia? TAL, micro or macro? Obviously, then microcytic hypochromic anemia, right? So it's microcytic and hypochromic. You can write that as reduced MCH and reduced MCV. Fine. That's a classical finding required here. Fine. If you want to add more information to convey to the examiner, I know more than microcytic hypochromic anemia. I'll give you a clue. I want you to tell what happens in that. What will happen to RDW in case of a thalassemia? There's a thing called as an RDW, red cell distribution width. What will happen in case of thalassemia? Will it be normal? Will it be widen? RDW is the degree of anisocytosis. In thalassemia, every RBC will be very, very, very small, right? Since every RBC is small, the range is actually normal, right? Perfect. There'll be normal or like Hriday said, no change. It'll be normal in case of a thalassemia. It'll be wider in case of an iron deficiency anemia or a nutritional anemia. Remember that this gives an extra point for sure. If you write RDW, automatically you can write men's index. Again, if required, write it. RDW is more than enough, right? Let's come to peripheral smear. Peripheral smear, here you can elaborate a bit. Again, I'm going to divide them as major and minor. For major, I'll have microcytes. You can write how do I call it a microcyte. If it's smaller than the nucleus of a small lymphocyte, we call it a microcyte. You can write it's be hypochromic. Again, if you want to mention, write why it's hypochromic. More than 1/3 paler in an RBC, we call it hypochromic. Fine. That's great, Vamish. It's easy to write DD of 65 femtoliters. Fine. See, if it's a DD of 65 femtoliters, the major ones, anemia, iron deficiency anemia, thalassemia, major, minor, alpha thalassemia, everything you can write. If you want extra, sideroblastic anemia, and a combination of, this should be more than enough. These are the things which can come into a DD of MCV of around 65 femtoliters. Fine. Okay. Yes, in case of TAL, RDW will be normal, Samantha. Fine. Okay. Then I want to write NRBCs. Nucleated RBCs will be seen only in major, it will not be seen minor, right? And obviously you'll have target cells. The only difference here in minor is, in TAL minor, I will see everything like a major. I'll have microcytic, I'll have hypochromic, right? There'll be no NRBCs. Because NRBCs is like a hemoglobin F. It will be present only when there is severe hemolysis. In case of milder hemolysis, like a TAL minor, you won't have them, right? Perfect. So once we have this, you will easily suspect the patient is having thalassemia. Obviously, you can go to the investigation of choice. What's the investigation of choice? Same thing as your sickle cell anemia, HPLC or hemoglobin electrophoresis, right? That's how you diagnose your thalassemias. Fine. Okay, that's how it is. We'll do it in the last crystal medicos. Fine. Perfect. So again, to complete it, we want to talk about management. So when you talk about management, what do you think is the treatment for thalassemia? You guys already know the treatment for thalassemia, right? Again, I'm talking about TAL major. Everything will be oriented towards TAL major because that's more life-threatening than TAL minor. Fine. Okay, I'll tell you, Amish, if the question comes that way, how to attend it. Fine. HPLC is definitely better, Samantha. Fine. Obviously, the first thing is blood transfusion whenever it's required, right? blood transfusion, and the blood transfusion most likely will be repeated. See, this is a second year student starting to learn medicine. Repeated blood transfusion is good. But once you have completed second year, when you know good amount of pharmacology, please include in addition with iron chelation. That's complete, right? Because repeated blood transfusion by default, you know, there's a risk of secondary hemocirrhosis. I'm sure Mr. read up about desferrioxamine, deferriprone, and all those drugs. Iron chelation is by default required whenever you give a patient repeated blood transfusion. So you talk or you listen or you think in terms of a doctor, not as a student. That will tell you, okay, I'm having a holistic approach, not just textbookish, right? And obviously, bone marrow transplantation is a cure which can be done, especially in case of a thal major. Fine. Perfect. Great. If you want to write desferrioxamine, right? If you know about the drug, amazing. If not, at least write iron chelator. Fine. Okay. Parmesh, if there's a question on differential diagnosis, right? This is for everyone. Any question which asks, give me DD for 65 femtoliter MCV. Okay. Just give me a second. Maybe I'll write this as a separate page. So if any questions which comes in this line, it might be helpful for you guys. Okay. Fine. See, if there's any question which talks about the differential diagnosis of 65 femtoliter MCV. When a question comes on differential diagnosis, I am not expecting from you just to say, okay, these are the 4 options. Differential diagnosis of fever does not mean that malaria, typhoid, dengue, that's all. You have to also tell how do I confirm the diagnosis. That's the goal of learning about differential diagnosis, right? So you say 65 femtoliters means I'm having microcytic RBCs. That's what it means. The conversion is microcytic RBCs. So whenever there's microcytic RBCs, there are 4 possible differential diagnoses, or 3 possible differential diagnoses, whatever it is, right? Right, as beta thalassemia, your iron deficiency anemia, alpha thalassemia if it's required, you can write it, sideroblastic anemia if it's required, right? I'm not including your anemia of chronic disease here because in anemia of chronic disease, the MCV, the mean corpuscular volume will be normal. I will see microcytes in microscopy, but it will never be 65. That's why I'm not including that, right? Now, these are my 4 differential diagnoses. The goal is how to confirm diagnosis. How to confirm? Confirmation will always have multiple things, right from the history, investigation, your probable investigation, and investigation of choice. Write a table. Write a table, right? If it's beta thal major, I can put one column as beta thal major, one column as beta thal minor. Alpha thal, if you want, write alpha thal major. The intrauterine one, that might not be required, just write alpha thal major, and then your sideroblastic anemia. Fine. Now, history. Beta thal major presents 6 months. Iron deficiency anemia can present any time, right? So write the history. Frontal bossing will not be seen in iron deficiency anemia. Clue, classical history. Then go with CBC. CBC, everywhere MC will be reduced. MCH will be reduced. That's where my RDW comes into play. Your RDW comes into play. Menstrual index comes into play, right? Then investigation of choice. If I have to confirm IDA, I obviously do iron studies. Write the iron studies finding. If it's an iron study there, write the iron studies finding. If it's IDA, say that ferritin will be reduced, iron will be reduced, all those classical things. And in case of an beta thal or alpha thal, do a hemoglobin electrophores, right? So these are not structured questions. You have to create a structure. Any question, if it's not a classical, like write a short note on iron deficiency anemia, you have to write a structure. And if any questions asking about the differential diagnosis, don't stop with naming them. Give a note on how do I confirm each of them, how do I approach each of them from the moment the patient walks into my OPD, from age, from symptom, from gender, multiple things, fine. Alpha thal's RDW will be same like beta thalassemia. It will be normal. It will be in the normal range. Inherited anemias, RDW will be normal. Acquired or your nutritional deficiency anemias, RDW will be wider. Fine. Clear, Mamish? Everyone, if there's a question which is very non-specific, take some time, 1 minute, think about it, write a structure, you'll be able to do well. Fine. Perfect. Let's go to autoimmune hemolytic anemia. So in case of an autoimmune hemolytic anemia, we have 2 types. Actually, there are 3 types. If you learn 2, that should be more than enough for us. We have warm and we have cold autoimmune hemolytic anemia, right? So the warm autoimmune hemolytic anemia, sideroblastic anemia, it's again, Samantha, I cannot differentiate sideroblastic anemia based on RDW per se. But sideroblastic anemia has both inherited causes and acquired causes. It's simple. If it's anything inherited, it will affect entire RBCs. So IDW will be normal. If it's acquired, IDW will be variant. That's how it is. Because sideroblastic has both etiology, I'm not commenting on that. Right? Okay. Warm autoimmune hemolytic anemia. For me, one of the important causes, it could be primary, which is idiopathic, which is both in warm as well as cold. It can be idiopathic. Secondary, I can have drugs which can cause it. Can give an example, alpha methyl dopa, which you must have read in pregnancy induced hypertension, or simple penicillin. Penicillin can cause it. And CLL, lymphomas can cause it. Here again, primary is idiopathic. Secondary, one of the important pneumonia, mycoplasma pneumonia can cause cold autoimmune hemolytic anemia, and also CLL can cause both warm and cold. That's etiology. Pathogenesis, write a template saying that it is type 2 hypersensitive reaction. That's how every autoimmune hemolytic anemia is, right? Warm will have IgG antibody, cold will have IgM antibody. If you want, write first warm, second cold. If you feel like I want to cover the same thing, right side warm, left side cold, right? So in case of a warm autoimmune hemolytic anemia, and in case of a cold autoimmune hemolytic anemia, right? So I'll have primarily IgG autoantibody, which is going to bind to an RBC. It binds to an RBC. There is a possibility there can be subtle damage. Not always subtle direct damage, which can happen, which can result in intravascular hemolysis. This is not the common one. So if you don't want to write it, ignore it. So I'm having IgG. When this IgG goes via the spleen, spleen has the macrophages. Macrophages will have the F receptor for the FC portion of IgG. So it will bind and it will be engulfed. This is how mostly it will be engulfed, right? That's how warm autoimmune hemolytic anemia pathogenesis. Cold is simple. It's IgM. Unfortunately, IgM cannot act alone. So when IgM goes to a colder temperature or the colder parts, especially like periphery of my fingers or the toes or ears or tips, right? It will activate complements. This complement activation will be incomplete for the reason it will come back into my warm zone again. It will not stay in my fingertips forever. It will just quickly come back, right? So this complement activation will result in my RBCs on top of them having complements. I'll have C3s, also I'll have IgM, fine. So this C3 and IgM, when it goes via spleen, the same route will happen. It will undergo engulfment or it will be lysed by my macrophage. Cold is purely extravascular hemolysis. Warm is also mostly extravascular. Tiny amount of intravascular hemolysis can happen, right? That's the pathogens of warm as well as cold, right? Let's come to history. History, again, the first thing is there'll be a trigger. You have to identify the trigger, be it a drug or an autoimmune condition, there should be a trigger. After that, again here also there'll be a sudden fatigue. It'll be a sudden lysis, right? So it'll be a sudden fatigue. Since it's all of a sudden, you might not have a very classical splenomegaly unless it's a long-standing thing. Sudden fatigue, you anemia or pallor, you go and start investigating, right? Everything normal suddenly becomes start investigating. Colder parts of my body, right? Purely extravascular is cold. Warm also is purely extravascular only, but theoretically speaking, for an entrance purpose, it can also have intravascular hemolysis. Fine line, okay. Let's go to CBC findings. CBC findings, both of them will have reduced hemoglobin. MCV will be normal here. Those spherocytes are smaller. It's a sudden one, right? So the mean will automatically normalize. MC will be normal. It won't have a problem, right? Peripheral smear, for every autoimmune hemolytic anemia, one is common. Again, so divide warm and cold. What's the commonest finding for both of the autoimmune hemolytic anemia? Spherocytes. Spherocytes is common for both warm and cold autoimmune hemolytic anemia, but for cold, because of IgM and IgM being a pentameric antibody, they can hold more than one RBC. What's a classical finding in cold? We don't call it cold alone, we call it cold agglutinin type, right? That will be a classical finding here. You'll have agglutinated RBCs. Okay, so agglutinated RBCs is classical for a cold autoimmune hemolytic anemia. You will not see them in warm. Warm will never have it. It's always agglutination, fine. So once I find spherocytes or spherocytes is agglutination, I'll go with an investigation of choice, which is undoubtedly Coombs test. If Coombs test is positive, my answer is different. Coombs is negative, we think of something different, right? Again, a simple word about management. What will you think is the management? Acutely, I use immunosuppressant, which could be steroids primarily. And obviously, the most important thing is removal of the trigger. Remove and avoid the trigger. If infection, if mycoplasma is the trigger, obviously what I'm going to do is I'm going to treat the mycoplasma pneumoniae. That will remove the trigger slowly. By the time in between, I'll do give steroids and immunosuppressants as well. Coombs test in detail. See, Coombs test is a very simple test. It's similar to what you do in your blood grouping and typing. Right? That's what is Coombs test. So what I have in Coombs test is, just give me a second. See, what we do in Coombs test is there are two types, direct and indirect. I'm saying about the common one is direct. Indirect is done only in case of an erythroblastosis fetalis. Fine. So what we do in Coombs test is we'll take the RBC of the patient, to which we add the Coombs serum. Coombs serum is nothing but it's an antibody to human immunoglobulin. It is a synthesized serum which is an antibody to human immunoglobulin, right? So we have RBC of the patient. We mix both, right? So let's assume that we are having a patient with an autoimmune hemolytic anemia, which means, can I say these patients RBC already on top of them will have immunoglobulin? They'll have. That's what happens in autoimmune hemolytic anemia, right? So now I add Coombs serum to it. Coombs serum, what it does is it will bind these both. Because they are antibodies to human immunoglobulin, it will bind to the immunoglobulin attached there, right? So this will cause clumping, clumps or agglutination. If clumping is seen, we call it Coombs positive. Like I said, similar to blood grouping. You must have added anti-A to blood group, anti-A, anti-B and anti-RH. Same thing. If it's their antibody, it will bind, it will form clumping. If it's a normal person, what will happen is, if it's a normal person, I'll have no clumping because I'll have only RBCs, and the Coombs serum cannot bind to anything because Coombs serum is an antibody to immunoglobulin. It cannot bind, so there'll be no agglutination or no clumps in a normal person. I hope it's clear. Fine. Again, if it's a long answer of autoimmune hemolytic anemia, try to explain it. Not required. If required, try to explain that. Fine. That's about few things about hemolytic anemias. Let's go to iron deficiency anemia. If I'm an examiner, I'll ask only one question in RBC, which is IDA. Because when you come out, the only thing which is you are going to see in your life is IDA. 100% of cases, even if you go to Africa, 90% will be iron deficiency anemia only, right? I hope the examiners also ask simple things about IDA because that's very, very important and an undergraduate needs to know about it, right? So etiology. Can anyone tell me etiologies? We have divided the etiologies based on children, adults and elderly. Children, one of the most common etiology in children is worm infestation, right? Now, since microbiology is over, you can write which worms. Necator americanus, Ankylostoma duodenale. If you're very good in micro, say that Necator loses 0.3 ml per day. So you can write all of them, right? Worm infestation is obviously one of the important thing, and obviously reduced nutrition. Reduced nutrition will happen in every age group, right? In adults, especially in women, one of the important causes menstrual loss. That's one of the important thing. Second, again in women, increased requirement of iron, especially during pregnancy. Obviously, when the woman is pregnant, she has to take care of two people's iron requirement, right? If it's not properly supplemented extra, it will automatically go into deficiency, right? Again, here also, I can have reduced nutrition. Malnutrition by default is one of the important thing across ages, fine? Elderly with an iron deficiency anemia, most likely it will be a colonic tumors. So colonic tumors might lose blood, like Samantha said, we'll have an occult blood in the stool, which can cause. Again, in elderly also, I can have malnutrition, right? Good afternoon, Rashri, right? All these are classical etiology of iron deficiency anemia. You can add more. You can write trauma. You can write any blood loss. Not only this, it could be a hematemesis due to variceal bleeding. Any blood loss, for that matter, will end up in having iron deficiency anemia only. Fine, that's one. So now pathogenesis. Pathogenesis, whether you are writing in detail or not, I want you to mention these three stages. Stages is not there in Robbins, but I want you to know there are three stages. We have learned them. Negative ion balance. In case of a negative ion balance, what happens is it's a very simple thing. Here, the iron loss will be compensated from ferritin by serum ferritin's iron. So automatically, why I want you to write this is automatically even the first stage serum ferritin will reduce. It will be compensated, no problem at all. Then for iron loss for even long duration, there's no nutrition for even long duration. I'll have iron deficient erythropoiesis, right? So what happens here is the bone marrow will have less iron. Because of bone marrow having less iron, it will start producing microcytes. Will I see them in microscopy? Very difficult. Unless and until I'm going to have the same thing going on for 1-2 months. Unless and until the majority of the peripheral smear blood vessels, blood cells are microcytic, I won't be able to see them at all. Fine. So it goes even for few months. Only then it results in a full-blown anemia where hemoglobin will be reduced, MCV will be reduced, MCH is reduced, everything will be abnormal, right? There are 3 stages. Okay, Samantha said there'll be bone marrow hyperplasia. Can anyone tell me whether it's right or will it be bone marrow hypoplasia? Samantha, you also. I'm not having enough iron, right? If there's no enough iron, bone marrow will not proliferate. You'll have bone marrow hypoplasia, right? It will not produce properly. It will be hypoplastic. Iron deficiency anemia is one of the hypoproliferative anemias, not hyperproliferative anemias. Fine. Okay, this is how it is. 3 stages are very, very important here. Fine. Okay, now let's come to clinical features. Fatigue, weakness, tiredness, by default, everyone. Can anyone tell me what's a classical nail change? That might definitely come in your exam. Classical nail change. Perfect, right? That's a koilonychia. Koilonychia is a very, very classical nail change, which is diagnostic or spoon-shaped nail. Hairs will become sparse. Sparse hair because hair is also keratin. Hair loss, everything, right? Koilonychia is a classical nail change scene. A sparse hair loss is also a classical symptom of iron deficiency anemia. Fine. Once that is done, obviously go for a CBC. Hemoglobin will be reduced. MCV will be reduced. MCH will be reduced. MCHC also will be reduced. Again, what will happen to RDW? Normal, wider, shorter. Both nutritional anemias, RDW will be wider. You'll have a wider RDW. If you want, write in brackets. That helps us to differentiate thalassemia minor, which is a very important differential diagnosis for a microcytic anemia, right? It will be wider, it will be, or it will become more. That's what happens to RDW, fine? So once that's done, I go to peripheral smear. Same, you can write microcytic. How do you identify it's microcytic? Smaller than the nucleus of small lymphocyte. Hypochromic. How do you identify it's hypochromic? You can write them. Okay. Then you'll have poikilocytes. One of the important poikilocytes needs mention here. What's that? One of the important poikilocytes is pencil-shaped cells. Okay. Pencil-shaped cells is a very classical finding seen in IDA. Maybe draw a diagram. Put a box again. Make sure whenever you draw pencil-shaped cells, it will be elongated and no hemoglobin or very less hemoglobinized. If it's very dark and elongated, it's an elliptocyte. That's very important, right? Okay, Vamish, what happens here is, in case of an thalassemia, I cannot use the same logic for the only reason. In case of thalassemia, what I'm doing is, I am kind of losing blood, and that loss which is coming from a stem cell will trigger the growth factors, which results in more and more and more cells, right? Any hemolytic anemia, when there is hemolysis, my response is to replace. But here, it's not a hemolysis. So imagine iron deficiency anemia is like, I'm having a person, not giving them food slowly and steadily over a period of year. He won't be able to eat much. But thalassemia is like, or any hemolytic anemia is like, I don't feed them for two times, morning, afternoon. Evening they'll eat more, right? Because sudden hemolysis. But nutrition starvation is very gradual, very, very slow. Obviously, at some point of time, bone marrow cannot proliferate, right? Okay, pessary cell is a normal RBC, which looks like a pessary. Pessary is, when you go to gynecology, you'll read what's a pessary. It's a ring. It's a ring. It's a very thin hemoglobin. It looks like a ring. We call it a pessary. Fine. Okay. So yeah, you can draw a tiny microcytic RBCs, put a new lymphocyte for in comparison, saying that it's smaller. Fine. Clear over mission line? Okay. So this is more than enough for me. If you want to write pessary cell, write pessary cell. That also is fine. Pessary cell is a very normal RBC with a very thin ring of hemoglobinization, fine. So once I know that, then investigation of choice. Investigation of choice in case of your iron deficiency anemia has only one person, it's iron studies. Without iron studies, you will not be able to diagnose it, fine. There are 4 iron studies. One is serum iron, then we have transferrin saturation. These both are directly proportional or inversely proportional. The next 2, serum ferritin and the affinity to binding ion, TIBC. This is directly proportional or inversely proportional. The first 2 are directly proportional. No, they won't be blue in color. I just wrote a different color, that's all. It's same, it's RBC, it'll be red in color only. Iron and transferrin saturation are directly proportional. So if iron is reduced, saturation will be reduced. Iron will go and bind to transferrin. If there is no iron, nothing to bind to transferrin, saturation reduced. Ferritin will be reduced in case of an iron deficiency anemia. If you want, you can write this. It's a most sensitive test and it's the one which will alter very, very early, right? And TIBC is the ulta, it will be elevated. Because less ferritin, less storage, affinity to bind with any amount of iron present will be more. So it becomes more, right? So these 2 are directly, that 2 is inversely proportional. So we know what's iron study, fine? So I confirmed it's IDA. Treatment. Now it's where your pharmacology comes in. Write whatever drug you want. I'm sure you must write ferrous sulfate, ferrous fumarate, multiple things are there, right? Ultimately, I need to give iron. So it could be ferrous sulfate, ferrous fumarate, whatever it is, based on the socioeconomic status. The most important thing here is you should not stop with treatment. The follow-up is very, very important. This please write if there's a question on IDA. Response to treatment, what you have to do is around 5 to 7 days after starting RBC. Okay, Pamish, tell me the answer. Everyone can tell me the answer. If I'm going to treat a patient with an iron deficiency anemia, I'm giving iron for the patient, and the patient is having, let's say that bone marrow is responding to it. What will happen to reticulocytes? It will be elevated, right? There'll be increased reticulocytes, which means the bone marrow is responding to it because I'm slowly giving the nutrition here. The patient is able to use the nutrition and the patient is able to respond to that, right? If after 5 to 7 days the patient is not responding, which means either the patient is not taking the drug or this is not working, that's all, fine? Okay, perfect. That's about iron deficiency anemia. Now next, let's go to megaloblastic anemia, right? Okay, great. So megaloblastic anemia, it's simple. Megaloblastic anemia means the first thing you should write, it's both vitamin B12 and folate deficiency. That's what is megaloblastic anemia and how to differentiate it from macrocytic anemia. Megaloblastic anemia, there are 2 main etiology. Vegan food, no animal protein, no milk protein, not vegetarians, vegans will have definitely reduced B12 by default, right? If it's malabsorption, it can start many places, fine? I'll do it, Samantha. Subsequent classes will definitely do it, fine? Malabsorption, in case of a megaloblastic anemia, it can start from your stomach. We can have pernicious anemia. Pernicious anemia by default, it can be megaloblastic, right? Because there's reduced parietal cell, reduced intrinsic factor, it can definitely cause it. If you want to write it, reduced intrinsic factor binding, it can cause it. Then chronic pancreatitis, because pancreatic enzymes are very important for me for absorption, that also will cause it. Then surgical removal of stomach, or you can write gastrectomy, or a removal of ileum, okay, that can also cause it, or an ileal resection can also cause it. Then we have something called a bacterial overgrowth syndrome, fine. If your bone marrow is not performing well, it reduces, fine. Fish tapeworm, see that's what happens. The good thing about second year is you can write many things. You must have read about Diphyllobotherium latum, which also causes megaloblastic anemia. You can include that as well, fine. Though that's very rare, but yes, you can include that as well, fine. So here, last but not least, you can have a cubilin mutation. Mutation in the receptor, that also can cause it, right? That's how it is. So all these things can result in malabsorption of vitamin B12. Folate, one of the most important things is excess requirement, which means an adolescent, pregnant women, Both of them, the excess requirement is going to definitely result in case of an folate deficiency anemia, right? It's requirement more, fine. Diet lacking foods and greens, because folate will be destroyed when we cook. Meat has good amount of folate, egg has good amount of folate, milk has good amount of folate, but when I cook, when it's heated, it will be lost. So fruits are the best source. So when diets are lacking fruits, vegetables, green vegetables which can be eaten without cooking, then you'll have folate deficiency. And alcohol, because alcohol will definitely inhibit folate absorption. That can also cause it, right? And one more drug. Can anyone tell me the drug which can cause folate deficiency? You must have read that if you give this drug in pharmacology, we have to not give folate, we have to give folinate or folinic acid. Anything? That's your perfect, right? Methotrexate. Methotrexate, dihydrofolate reductase inhibitor. The biologically available folate will not be there. That also MTX is for methotrexate, which also causes the same folate deficiency, right? So I know the etiology of folate and B12 deficiencies, right? Now coming to pathogenesis. Both folate and B12 deficiency is about your nuclear cytoplasmic asynchrony. See, I have not talked about absorption, but it's a long answer. Talk about absorption. Same iron also. If it's a long answer, talk about absorption, because if it's a long answer, they'll give 2 marks for absorption, 2 marks for etiology, 2 marks for pathogenesis, 2 marks for investigation. Based on that talk. If they're not talking, don't talk about it. Fine. It's nuclear cytoplasmic asynchrony. Because of reduced folate or B12, what happens is there'll be a reduced nuclear maturation. That's what is nuclear cytoplasmic asynchrony. It won't mature properly, but cytoplasm will be completely normal. But cytoplasmic maturation is completely normal, because cytoplasm has proteins. Proteins and RNA have uracil, not thymine. Thymine is the one which will be abnormal in case of a B12 or a folate deficiency, right? It is completely normal. Because of a reduced maturation, what happens is you might see retained nucleus in RBC. Because in RBC, maturation is the nucleus becoming small and disappearing, right? So you'll have retained nucleus or nuclear products in RBC. Or it will take lots of time to eliminate them, so it becomes bigger, right? So you can see nucleated RBC in case of an megaloblastic anemia. You can see your basophilic stippling in case of megaloblastic anemia. The stippled RBCs, which means they are nuclear material which is still retaining there. Or I can have a macrovalocyte. We can have that because for me to push it, I am pushing it very earlier, so it's still bigger. It's not yet matured and becoming smaller, fine. Or in case of a WBC, I can have a big blast. That's a name came, a megaloblast. Okay, it's a megaloblastic anemia, a megaloblast. And the second thing, hypersegmented neutrophil. Because it's a big nucleus, segmentation of the nucleus also becomes more. That's all. The chapati dough is big, chapati becomes bigger. It becomes a Romali roti, like that. Hypersegmentation happens here. Stippling is nothing but the nuclear dots is not completely removed, retains there. We call it basophilic stippling. Fine. That's what happens here. But your hemoglobin production will be absolutely normal. It looks well hemoglobinized. It will be normal red color. It will not be pale in color in case of a megaloblastic anemia, because cytoplasmic maturation is completely normal. Fine. Okay. Let's look at clinical features and lab diagnostics. No, Punit, whole jolly body is a single inclusion which is seen when spleen does not function. Okay. Basophilic stippling looks like this. It's stippled. It's all over. Whole jolly bodies is generally a single dot. It's not been removed, right? That also is a nuclear remnant, but it's two different conditions, two different outcomes. Fine. Okay. So let's look at the history. Okay. If you look at history, we already have learnt about megaloblastic anemia in a very different way. We know about normal B12, and as I told a story about B12, then we would have linked it to megaloblastic anemia, right? History-wise, one of the most important thing is, obviously, like as usual, you'll have symptoms of anemia, which is fatigue and tiredness. That's by default. The classical finding is your perfect red beefy tongue, knuckles becoming hyperpigmented, altered bowel habits, having a very thin skin which can increase easy bruisability. All those are classical symptoms, right? You can have a red color and a flat tongue. You can write it as red beefy tongue. It will be flat. You won't have the papillae. Knuckle hyperpigmentation is a very classical finding. Don't forget it. Okay. You'll have altered bowel habits. It will not be normal because your intestinal villi also requires B12, right? And you have your easy bruises, easy bruisability because skin also is very, very, very thin. This is common for both B12 and folate. That's important. And whatever Samantha said, neurological defects, right? The subacute spinal cord degeneration, the position, vibrations, everything becoming normal. Instead, if you can write in that level of certainty, write them or just write neurological symptoms. B12 or folate or both. It's seen only in B12 deficiency. If you want, right, because for sphingomyelin is a myelin product which requires B12. So obviously when B12 deficiency, myelin will not be produced properly. So I have all these problems, right? Perfect. Difference should be clearly mentioned right from the history. For CBC, the only thing, my MCV is going to be bigger, right? More MCV will be there. The mean corpuscular volume becomes more, that's all. Peripheral smear, it's simple, you guys know. You can write macrovalocytes. Other one is hypersegmented neutrophil. Macrovalocytes a very early finding. Hypersegmentation is a very, very classical or a specific finding, right? You can draw a WBC neutrophil with multiple lobes. Anything, even a single WBC with more than 6 lobes is definitely hypersegmentation, right? It is. It looks normal. See, because what happens here is hemoglobin, the cytoplasm looks normal, MCH is normal, MCV alone is elevated, fine? Okay. Okay. Now then, your RBCs. RBCs will be bigger, will be oval. For comparison, draw a tiny nucleated lymphocyte, right? So just for comparison, so you know it's a macrovalocyte and hypersegmentation, which is classical. And like Vamesh said, it'll have good amount of hemoglobin. Hemoglobin will not be a problem here because hemoglobin is properly produced in case of a macrovalocyte, right? Investigation of choice. How do you investigate? How do you investigate? Simple. Do a B12 and a folate assay. Final thing is obviously going to be with the help of B12 folate assay. If it's reduced, it's reduced. I cannot contemplate that. Obviously, I'm going to replace them. Fine. Anisocytosis can be seen, but poikilocytosis is not very common in case of a B12 deficiency. Anisocytosis changes shape, sorry, size. It can definitely be seen. Shape change is not a very classical finding of a B12 deficiency. Fine. Okay. Treatment. Treatment be very specific. In case of B12 deficiency, treatment is only B12 replacement. The older way of understanding was if B12 was deficient, give both B12 and folate. Now it's completely changed. It's been changed for 5-6 years. If it's B12 deficiency, replace only B12. Okay, replace only B12. That's how it is. And if it's a folate deficiency, replace only folate. Replace whatever has been deficient. That's how we're going to treat case of an B12 or folate deficiency or any nutritional anemia for that matter. Fine. In B12, because folate will not be involved in that, Punit. It's more of sign of a B12 deficiency, though we don't do it routinely. See, the reason why I didn't mention about methylmalonyl-CoA is, if I can do classically B12 levels and folate levels, why should I do an indirect test to prove it's folate deficiency or B12 deficiency? It's a blood test. Instead, I can assay B12 and folate directly rather than doing them. Theoretically, yes, B12 will have that, folate will not have that, right? Samantha, it's macrocyte only. It's a big cell, so kind of looks elongated, stretched when you make a smear. So it appears like an oval cell. That's all. It's macrovalocyte. Okay, fine. So that's about RBC. We have seen quite a few RBC disorders. What I have not talked about is PNH, not very important, and aplastic anemia. These two I want you to read. We'll put a few cases. Aplastic anemia might come, but not very important. So rest of all the anemia is done with. Use a template. Whatever question comes in anything, template and presentation is more important than that, right? Coagulation I'll do sometimes later, Samantha. We'll go one by one. I'll do it for sure. I can do it on the afternoons also. Whenever you have in the evening of pathology, we'll do tiny things of 2 sessions, 45 minutes, so it makes easy for you as well. Fine. Okay. We'll see Samantha later on. Okay. Any doubts here? Let me know. Okay, guys. We'll keep you posted, Samantha. Don't worry. Today, I think evening you have pharmacology. Once it's over, let's see. Thank you, guys. Bye bye.